Thanks for coming today. I know I am the person that's in between you and a Chick-fil-A sandwich or wherever you're trying to eat here today. So I appreciate you stopping in. I am Julie Hiett. I am with Netsmart, and I realized I don't have a slide to tell you about Netsmart, but we are a technology company, surprising here at HIMSS, right? But we're focusing on think about everything outside of the EHR. Or excuse me, the hospital. We are on the population health side, electronic health records, etc. And we'll talk about that today. I'm going to mostly focus on our behavioral health side of our business. So today we're going to talk about what's that ecosystem like. So oftentimes when you come to HIMSS, you're thinking about primary care and in the hospital and whatnot. But there's a lot of other ecosystems out there that people are touching, and that's what we're going to talk about today and how that interacts with AI automation to help those folks out. And then, of course, talking about our collaboration with AWS and what we have in the works together with our partnership. So let's talk a little bit about behavioral health. Today, just what's the world look like in the United States? So nearly 50 million or almost 20% of Americans, adults are experiencing a mental health problem in any given year. So that comes down to in any state, so whatever state you live in, 1 in 3 are going to go without treatment. And why is that? There's a million reasons why. We know with stigma and access to care, there's lots of different reasons for that. But we are in a mental health crisis in America, and what we need to be able to do is pull in that data along with everybody else that is working with that person so we can really make a difference in those people's lives. So at the same time of having a behavioral health crisis, we also have the industry challenges. So much like a lot of other industries in America post-COVID, mass exodus of social workers and counselors and case managers, et cetera, leaving the profession. Also, caseload overload. I'm going to talk a little bit later about a client that we work very closely with, and their nurse care managers have 250 people on their caseloads. There's no way without automation and AI that they would know, who do I need to reach out to today? Who has a problem that I need to interact with? And then, of course, those providers that are doing this work are burnt out. Part of that reason is because of the documentation that they need to do. Nobody joined behavioral health to spend their time with documentation. Nobody says, I'm going to do this because I love documenting in an electronic health record, right? Nobody did that. They did it because they wanted to help somebody, they had a personal experience, etc. So what we need to do as technologists is help them do better in that job, help with that burnout, help them to be able to streamline those processes. Along what's happening in the industry, then you look at the workforce demand. So like I said, we had a mass exodus of folks in behavioral health around COVID. Part of that, there's a million reasons, like I said. Part of that is pay. Part of that is, going to school. Do I spend my money on trade, et cetera? So the supply and demand is really important. And I'm actually surprised on some of these numbers. So you think about today, you have all of this tech that someone can be texting with a counselor, right? That's why that counseling number looks so high, because we need people that have the experience to be able to help people across the country. I was a social worker. People wondered if you didn't know what that MSW at the very beginning is, a master's in social work. And you're probably wondering, why is somebody in social work talking about this? But the reason is because these are the people that need us to look at what's happening in their ecosystem and make that easier for them. So not only do we have supply and demand, we know that we have more people with a mental health crisis, and we also have the most exciting time in technology. So we have the opportunity to have the person in the middle of their care. So what we would call a patient-centric model. And at Netsmart, that's really our focus. So at the end of the day, how can we make a difference for the person that is using that technology, but also the person that they're serving? And obviously, you've been walking around here the last couple of days, and everybody's talking about data and AI and automation, right? So the difference here, what we're doing with AWS and Netsmart is that it starts with the person and then it expands from there. So at the end of the day, how can we make a difference in that person's life? How can we use their quote unquote data in order to make sure that they get the help that they need at the right level of care at the right time? But in looking at this, you think about digitizing the enterprise. Oftentimes, people think that that stops with the electronic health record. I document in that electronic health record, I have everything that I need. Maybe I have a little bit of automation or a work list that tells me what I need to do. But we know that the EHR only holds certain data. It's not going to tell you the Medicaid claims, or it's not going to tell you if that person is homeless or not, or if they're receiving services, a social service event, et cetera. So what we need to do is be able to look at all those systems, bring that into a view where that person is centric, and we can then automate the workflows for the end user to then be able to help that person at the right time. So how are we going to do that? So I'm going to talk about two different examples. We have a lot more than that, but they only give me 15 minutes. So I'm only going to talk about two of them today. But the first one we're going to talk about is automation. Like, obviously being here at HIMSS, we want to talk about the big innovative things, and we're going to talk about that here in a minute. But really, it's the little things that make a difference for our end users. So we know that AI can help improve clinical care. What does that mean? It means that I can log into the system as I start my day and I know what I need to do. I don't have to run a report, call IT, know what's happening. We can use interoperability to bring data into the system. We can look at what's happening within the data within an EHR or another system and improve that clinical care. So again, helping that person at the right time. Also, at the end of the day, we're all running businesses, right? So maximizing reimbursement. We can do that with documentation. So making that a quicker workflow for them, making sure that we have the right wording and the right information in there so it's not going back and forth between the biller and the clinician, so people can get paid quicker. And then, of course, staff retention. So we talked about earlier, we have a workforce shortage. We have a higher need for mental health services across the country. And quite frankly, as we have newer people coming into the workforce, they expect AI. They expect software that is innovative and whatnot. They learned it in school, whereas I'm not going to tell you how old I am, but I didn't learn that. I learned how to do a Word document in an electronic health record, and that's as fancy as we got. Now people in the workforce are expecting more from us. So the first example I want to talk about is documentation. So again, we have seen studies that show that over 40% of a caseworker's time is being spent documenting or mining data to know what's happening with the people that they're serving. So Bell's AI is one of our products at Netsmart that is helping with that documentation within the EHR. Doesn't have to be a Netsmart EHR, it can be any EHR out there. So walk around the floor and we can integrate with those. And this is an example of Integral Care, which is one of our clients. And they use Bell's AI with their clinicians, and just a quick example of how that is making a difference for them. So for example, if I'm out in the field talking to somebody and I'm just taking some quick notes on my phone, I can get back in my car and push that to the electronic health record. I can clean that up. So the easy things like spell checks, etc. But I can also see suggestions. So Bells can tell me if I write in my clinical note, I drove Susie to her appointment. Well, driving isn't a billable service, but supporting Susie in XYZ is a billable service. So we've worked with our providers that are using the system, but we've also worked with state systems to hear what they have to say, right? So they get worried about AI, it telling them what to do, or everybody's note is exactly the same. And Bell is very configurable, so it can help with that clinical documentation, streamline the workflow. So going from 4 minutes That's usually would take somebody an hour. You think about that caseload that I just talked about, you're spending your whole time with documentation. So Bells really helps with that. And as we work with providers and systems, we know that making that faster means we can see more people on any given day and the satisfaction of the people that we're serving. So what does this mean for behavioral health providers? Both a clinical impact, so increasing access to care. We talked about that. So if I can document quicker, I can have more appointments, I can hire more staff, etc. Improved ramp time. So I can tell you, when I first started as a social worker, I didn't know anything. I was 23 years old. I don't know what a SOAP note is or a SMART goal, all of these things that I have to have in order to get reimbursed in a note. So it improves that RAM time. So right now we have lots of people that use QA and QI in order to review notes before they're finalized, in order for them to go to billing, et cetera. And now we can speed that up. And then of course, morale, less turnover. If I have I can make that documentation process easier. I'm more likely to be happy in my job. I'm less likely to have burnout. And now I can, again, continue to do what I need to do and why I started. And then, of course, the financial impact. Again, at the end of the day, this is a business. So we can create more revenue. We don't have to train somebody to then be there for 2 months to then leave and have to train somebody else again. So there's a financial impact on that side. And then there's AI that we can use not only on the documentation side, but AI on the reimbursement side or the billing side of the house to make sure that we are using AI to then check for mistakes or check if there's missing information, et cetera. So switching topics here and looking at population health. So again, at the top, this is where the easy or the more simple things make a really big impact. So we have today limited data sets. So we talked about data within the electronic health records, right? So that's limited information, but there's a plethora and really good data in there. And we can run automation or AI in order to close gaps in care. So if I am working with somebody that has schizophrenia and diabetes, and we do a yearly lab and that person's A1C is really high, instead of having to look at the lab and then make a decision on what we're going to do, once that lab hits the system, I can automatically generate a list that says, okay, these are people that need a follow-up and they need that follow-up immediately, and here's what you need to do as a result of that. And then, of course, predictive care. So if we have systems that have lots of data in it, we have the ability to run these predictive models in order to know what are those gaps, who's somebody that's more likely to trend in a certain way. So using business rules and that tech to generate machine learning in order to tell us who's most at risk, who's trending up, so we can intervene before they become in a crisis situation. And then, of course, who needs that follow-up afterwards. But now when we start looking at the power of working with AWS and having data in a data system, now we can expand that data set to other larger systems. So those national data sets, in the example I'm about to talk about, we have data from Medicaid. So daily Medicaid claims data matched up with behavioral health electronic record data, along with information about homeless systems and social services. And now you start piecing together that whole person view of that client and can really make a difference with that larger data set. So what we're working on with AWS is a couple of risk models. And we know, again, need a lot of data to do that. We're going to start with a risk of hospitalization model. We're going to look more at SDOH. So the hot topic today is those social determinants of health. I can tell you as a social worker, we knew that a long time ago. Technology this is the one place where we're kind of catching up with that. It's so obvious, right? But you need the system to tell you, if I haven't eaten in 2 days, I'm probably not taking my medication, or I'm not going to show up to the appointment if I live 15 minutes away from the bus line. So all of those things are really important information that we need to know as technologists, as in order to utilize that data to help the end user. So one example, and following along with the SDOH predictive models. So oftentimes that data, as we know, is not discrete data. It's sitting in someone's progress note or that SOAP note that we talked about earlier. So we're working on some predictive models to take just specifically to SDOH, mining that data in the notes that I talked about earlier. So we have the AI, it's making that streamlined process easier. Now we can look at that data and say, hey, this person's more likely to have something happen as a result of this that you may not have caught, or the next person in the process may not have caught because they didn't read the last 5 notes. We can bring that forward. So in talking about what we're doing with AWS, again, some really cool um, scenarios as a result. So Missouri Behavioral Health Council, so that's the MBHC, they're what you would consider a trade association for behavioral health in the state of Missouri. And they have members that are representing all of community mental health centers across the state. So rural, urban, there's about 36 community mental health centers as well as substance use providers that are all part of this collaborative. And we are bringing in a robust data set into AWS from those electronic health records, getting data from the state, getting data from Medicaid, putting that all together, and then running AI and lots of other really cool things in order to kind of make a difference or take the next turn with that population. So this is an example here in thinking about the ecosystem again. On the left-hand side, if I am Julie Hiett and I have a behavioral health problem, my data is not just in my EHR like we discussed, right? That data is in a lot of different systems. So starting on the left-hand side, I could have been involved with law enforcement. So maybe I had an episode and law enforcement was called out to do a wellness check or whatnot. So there's information in a police report somewhere. I could need to go to a food pantry, or I need, anger management, whatever it may be. So on the left-hand side, lots of different systems. Bringing that into the AWS data mesh, now we can start bringing in information from other systems. So that person probably has information in primary care system somewhere, in a hospital system somewhere. So looking at the right-hand side, as that person goes through their continuum, so maybe they started, quote unquote, in the system as a young adult and now they're aging. So maybe they've come in and out of other systems, bringing that all together into the data mesh, and now we can start driving AI and automation so we can push that down to the end user. And at the end of the day, if we do this right, then the person, so always going back to the person that's being served, they will feel a difference as a result of that as well. So this is an eyesore, really cool if you can see it, and when we're thinking about hospitalization and suicide risk, there's a lot that has to go into play. I love my friends at Missouri Behavioral Health Council, but they have this idea that data comes in and you can immediately do something with it and push it out, right? And we can do that when you have partnerships like AWS and Netsmart has in order to look at all of these different systems. So now we can use that SageMaker to run AI. We can talk about new technologies with Claude 3 and really take all this robust data and do something with it in order to, again, make a difference to the end user. So once you have all of this going, as an end user, I can log into this population health platform, and now I can see the insights. So I can see what's happening with those 250 people on my caseload. I know that Austin here is trending up, but what's making him trend up? What's that risk profile look like? And I can just click on that, and the insights are going to be at my fingertip. It's not that I have to go read the last 5 notes. It's not that I have to go look at his labs. It's going to tell me all of that right here. So what are those positive influences? What are those negative influences? What's that risk profile look like? And then what can we do with that information is really what's the next step in that process. And then of course on the right hand side, again, that's data in, data out. So that's, we're just feeding the machine, right? Feeding in new data within the care management and population health solution, getting them from those external sources. And now we can start really analyzing and run machine learning on that. So if I'm administratively, so now I'm stepping back a little bit, I can look at an example of the state of Missouri, and I can see where are we having more crisis incidents at. rural part of the state, in the urban areas, what's the demographic look like? What's the interactions that that person has had with either behavioral health or other systems outside? So it really allows us again to go from, in my eyes, going from the person and that whole person care view, expanding out to the population, and then being able to push those insights back to the end user. So I am a happy worker, and when I'm not burnt out, as well as making a difference in the people that we're serving. That is it. So thank you.